So it's 1 minute past, so should we get cracking? Thanks everyone for attending online, and also we have a few select members of the audience in the room as well, which is great to see. So today I'm delighted to welcome Dr. Jordi Serra, who's a consultant in clinical neurophysiology at King's College Hospital. Dr. Serra trained as a neurologist in Barcelona before moving to Oregon to work as a neuromuscular fellow at the Oregon Health Sciences University before moving to King's. And Dr. Serra has a particular expertise in microneurography, which he will be telling us all about today. So take it away, please, Dr. Serra.
Okay, thank you. Thank you very much. So let's see how it works. Let me know if there is any interruption or anything, because I don't have the feedback of my own slides, so I will carry on. So what I would like to discuss today is the findings or the awareness that we are getting now of different pain conditions in humans that we thought at some time ago they were kind of mystery diseases or strange things that were happening in humans that nowadays or recently with the use of microneurography we are beginning to understand, or we are trying to understand a little bit better what's going on with some of these patients. So today I will be talking about what is microneurography. Forgive me, it's a little bit technical in the beginning, but I think it's necessary to understand what the technique is and can offer. I will touch a little bit on fibromyalgia, and I will finish with some reflection on what may be happening in other pain conditions, chronic pain conditions in humans that up to date, we don't have a clear understanding what's the background of them. So you all know that in a peripheral nerve, and let's go into focus immediately, there are different types of fibers, large myelinated fibers and unmyelinated fibers. The large myelinated fibers basically are composed of the motor axons. Your brain gives the command to contract a muscle, and it sends action potentials through the pyramidal tract, and then it goes into the alpha motor neurons in the anterior horn of the spinal cord, and then this goes into peripheral nerve, and you release some substances in the muscle and you contract the muscle. And then the other type of large myelinated fibers are the sensory afferents, mostly coming from the skin, but also deep tissues, but the skin in which you have different sensory receptors for the sensation of touch and pressure. The problem with recording different fiber types is that the electrophysiology of large myelinated fibers is relatively easy, and this is because they produce large action potentials and they are highly synchronized. So when you have you deliver a shock to the nerve, you will have a nerve action potential, a compound nerve action potential, which is the summation of the different individual action potentials, and this will produce a large, very large compound nerve action potential that can be recorded from the surface, and this is the basis of nerve conduction studies. The problem is that in the nerve, there are many other fibers that are very thin, the unmyelinated fibers. They are, engulfed, so to speak, within individual Schwann cells. And these fibers, they produce very tiny action potentials. The current they produce is small, and they also have a wide range of conduction velocities, at very slow conduction velocities. So that means that the ability for these fibers to synchronize and the action potentials to summate one on top of the other is very low. So the end result is that you have a compound nerve action potential which is very small and very dispersed, very broad. So this small, broad action potential cannot be recorded from the surface of the skin. So that's a big limitation, because nerve conduction studies, which are the basis of the study of large myelinated fibers, cannot be applied to these small unmyelinated fibers. So we have had to develop different techniques to be able to record from these fibers. One of these techniques is microneurography. And I always say that
can I just jump in a sec? There's a little box at the bottom we can see that says Teams, Microsoft is showing the screen. Could you click hide on that? Brilliant, thank you so much.
Sorry for that, yes. So I think it's all about techniques, right? I would say that many of the advances in medicine have been linked to the availability of new techniques. I mean, if you think about something as common today in terms of diagnosis as epilepsy, and you think about what doctors or what medicine knew about epilepsy 150 years ago, 100 years ago, it's completely different from now. I mean, if you can imagine a patient with a elastic seizure, for instance, or a patient with some complex automatism because some temporal epilepsy, And this been seen by a doctor of, the 1900s. These patients were a kind of mystery patients, and they were sometimes labeled as crazy or, or possessed by the devil, or you name it. So it was not until somebody invented a thing called EEG, in which you apply some cables into the scalp of a subject, and you see that, oh, wow, all of a sudden this patient that every time has a elastic seizure, every time has a complex temporal seizure, there is a pathological discharge, or there's something abnormal in the rhythm of the brain. And then little by little, this technical advancement opened the field, and all of a sudden you realize that epilepsy it was a disease with a cause, and we are beginning to understand it much better now. And this was linked to a technical advance. I would say that with pain, we are at the same stage. Up to now, we didn't have so many tools to study pain, what pain is. So we were thinking that many chronic pain conditions in humans, in which we were doing several techniques, imaging studies, conventional nerve conduction studies, and we didn't see anything. And many of these patients were ended being labeled as like epilepsy 100 years ago. Some of them are psychological, some of them are psychiatric patients, some of them are, functional patients. And it's not only these new techniques have been developed, that we are beginning to have a different view about that. So look at the techniques we have now in the clinic. Negative phenomena means deficit. You have a hypoesthesia or an anesthesia or a paralysis. And positive phenomena is you may have paresthesia or you may have pain. Pain is a classic sensory positive phenomena. So if you look into the different types of fibers, you will see that for negative phenomena, we have lots of tests that we can apply, particularly nerve conduction studies, EMG, but also, somatosensory evoked potentials, and you name it. But for positive sensory phenomena coming from unmyelinated fibers, so positive sensory phenomena relating to pain, you will see that we are very restricted. And in fact, we only have two things. One is quantitative sensory testing, which is a psychophysical test. Yes, it will tell you which is the sensory abnormality in the skin or in the deep tissues, but it will not inform you too much about the mechanisms. And then the other one, the only one that we have, is microneurography. Okay, so microneurography, I think, is very well placed to try to help us understand what's going on with these patients. So that's how microneurography works. This is actually the unit at King's. You have a recliner, you have a subject, and then you have some electronics here that record from the foot. So you apply a head stage here, and then you have two microelectrodes. One goes into the skin, the reference electrode, and one goes into the nerve, the active electrode. And we normally use the superficial peroneal nerve in the foot because most of the patients we are receiving are patients with a suspicion of small fine neuropathy. So that's a very convenient territory to access the peripheral nerve fibers. So this is the general setting. Once you have the electrodes into the nerve, then you stimulate the receptive field of the superficial peroneal nerve with a pair of needles, and you deliver a tiny electrical shock, and there is a distance between your, the delivery of your electrical shock into the receptive field and the recording electrodes. And then you get something like this. So you zap the skin with a tiny electrical shock. You feel like a little tiny prick, which is not unpleasant. And then you have a sweep in which you have different deflections. Okay, each of these deflections is an individual action potential. So that's a concept that has to be placed in our minds when we see the recording from microneurography. These are not compound. These deflections are not like a sensory nerve action potential when you do carpal tunnel. Each of the deflections is an individual action potential from an individual fiber. Because we have the distance here and we have the latency at which these things occur, we can easily calculate which are the conduction velocities. So if this is occurring at 10 milliseconds for 100 millimeters, this is 10 meters per second. And then there is nothing in between, and then there is a second group of fibers that conduct much slower, 1 meter per second. So this is basically a single sweep here. So imagine that instead of a single sweep, you begin giving many sweeps, okay? So you have the first sweep here, and it's obvious that there is an action potential here and here and another one here. I don't know, by the way, if you see my mouse. No answer. Hello?
Yeah, sorry. Yeah, we can see your mouse.
Okay, sorry. So you have the different action potentials here. but you don't know what's going on here. Okay, so but if you keep repeating the electrical stimulation and you keep putting sweeps one on top of the other, it's very easy to agree, all of us, that there are many action potentials that repeat, and they repeat at the same latency. They top-down cascade is that even this thing here, you see this little thing, you never know whether it's an action potential or not because it's very small. But if you keep repeating, you will see very clearly that's repeating at the same latency all the time. So that allows you to record from many action potentials simultaneously, even with very poor signal-to-noise ratios. So this is how it works. We have an action potential, and I keep repeating, and you see that there is always an action potential. Visual aid to the thing, and I can put a dot on top of the peak of the action potential, so it's easier for me with a visual point of view to see it. And I can even make things easier by removing the actual sweep, and I just keep the dot. So if I keep the dot at the peak of the action potential, this is when my action potential is occurring every time I deliver stimulus into the skin. Okay. If instead of doing, and this is an important thing, a top-down cascade, I do a right to left cascade, then I have something like this. Okay, the latency all of a sudden is not in the x-axis, the latency is in the y-axis. Okay, so there's a unit here occurring around 110 milliseconds. Okay, so this is how it looks. These are 2 units, and they have this latency, which is stable here all the time, 120, 135, for instance, and I'm stimulating this unit at very low frequency. But then all of a sudden, what I do is I begin increasing the frequency. Instead of stimulating at 0.25 hertz, for instance, once every 4 seconds, I begin stimulating at 2 hertz, 2 impulses per second. So what happens is, and this is the crucial point to understand microneurography, is that these fibers, these C fibers, are very bad at following higher frequencies of stimulation, and they slow down. So when they slow down, of course, the latency goes up, as you see here, okay? And they produce these beautiful profiles of what thing that we call activity-depending slowing of conduction velocity. This activity-depending slowing of conduction velocity is a thing which is embedded in the membrane of the axon. So it's not a thing that you can influence. It's a thing that the fiber will always respond the same way. And it's due to the specific repertoire of sodium and potassium ion channels and PAMs and other channels that these fibers may have. And this is what characterizes and defines how the membrane responds. So this is an example again. So we are stimulating at 0.25 hertz, and you have this kind of very flat lines. If you stop stimulation, nothing happens, of course. You can resume stimulation at 0.25. You go up to 2 hertz, and then you have this slowing of conduction velocity, which is an increase in latency. Okay, it's the same. If you increase latency, it means it needs more time to reach your recording electrode, so the conduction velocity is slower. And then you stop 2 hertz, and it comes back to normal. So all C fibers at low frequency, they settle, and they have these flat lines. And at high frequency, they slow down, and they produce this kind of fish fins. Okay. The interesting thing is that the different subpopulations of C fibers in the periphery, they produce specific types of activity-dependent slowing profiles. And this is very useful because this is an actual recording, for instance. You have all the different fibers, and the program can extract different types of fibers. And you immediately see that there are shark fins, so to speak, and kind of plateau units, for instance, different behaviors. And this shark fin has almost no slowing after the 2 hertz, whereas this one has a lot of slowing after the 2 hertz. So there are different profiles. Over the years, we have been studying these profiles, and we know now what they mean. And the interesting thing is that the shark fins, the ones that slow down like these, correspond to the peripheral nociceptors. And it's not only, and that's very beautiful in a way, right? Because by inserting a microelectrode into the nerve and then playing some tricks with electrical shock stimulation rates, you produce these activity-dependent profiles that allow you to say, okay, this fiber I'm recording is this type of fiber or this other type of fiber. So it's not only that I can distinguish, or we can distinguish between nociceptors and the rest of C fibers, but we can also distinguish between the two main classes of nociceptors. So the common C polymodal, or the mechanosensitive nociceptor, the normal nociceptors, quotes and quotes, which is purinergic and it does not depend on NGF. And then the silent nociceptors, which are the mechanoinsensitive, which are the peptidergics, are the ones that are in charge of producing neurogenic inflammation. They contain CGRP and substance P and all these neuropeptides in their terminals. Okay, and these two types of nociceptors are very important because they get affected or they get dysfunctional or abnormal in different types of diseases. So here you have, again, all the fibers, different fibers, and the C nociceptor, remembers they have this shark fin profile. So what can you see abnormally in these patients or in patients with chronic pain conditions? Of course, when we began doing microneurography, we started with patients with bilateral burning pain in the feet with a suspicion of small fiber neuropathy. And now, over the years, we have expanded the populations of patients, and this is what I want to explain to you, what we are beginning to find in other subsets of patients. So these are some of the abnormalities you can see in these patients. Basically, spontaneous ongoing discharges, which we claim is the electrophysiological correlate of spontaneous pain. Peripheral sensitization, which is probably the electrophysiological correlate of hyperalgesia or hyperesthesias. And then multiple spikes and changes in axonal membrane properties that I will touch briefly. So first one is spontaneous ongoing activity. So when you have a C fibers which is stimulated at low latencies, low frequencies, as I was telling you, they all settle in a kind of stable frequency, stable latency like this, and they produce this kind of flat baseline. Okay, so you have the action potentials here, and this is the same with the sweep or only with the point. And you see it's a flat baseline. But when you have a spontaneous activity, when the fibers are spontaneously discharging, what happens is that between, and this is a difficult concept, between my electrical shock and my next electrical shock, depending on how many action potentials this fiber has generated on its own, there will be more or less activity dependent slowing. So the fibers will be fluctuating in a kind of sawtooth baseline. So this is shown here, for instance. So the top fiber is a nociceptor that's producing these flat baselines. And this one here is an abnormal nociceptor, which is interrupted with this kind of sawtooth discharge or sawtooth profile. Okay, both of them have the shark fin, both of them are nociceptors. So you can see that there are very different profiles and very characteristic profile of when a fiber is spontaneously active. This, you see it here, he is a healthy volunteer with all the shark fins and very flat baselines. And this is a patient with a painful diabetic neuropathy. And you will see that many of these shark fins are, interrupted by this kind of sawtooth here, and here you see many sawtooth. So these patients with spontaneous ongoing burning and deep aching pain, when you place the microelectrodes inside the nerve, you see that the C nociceptors are engaged in spontaneous activity. So for us, this is a very compelling evidence that most probably the experience of pain has an origin in the periphery. That doesn't mean that the brain does not modulate the experience of pain. Not at all. We are not claiming that. We are claiming that the origin of the spontaneous pain of these patients is probably an abnormal generation of action potentials in the periphery, in the peripheral nerves of these patients with neuropathies. So that's another example, very clear. You have this baseline and it's completely interrupted by this ongoing thing, up and down, this sawtooth profile. You have another example here at the top, and here on the left you have two nociceptors which are normal, and here on the right, two nociceptors that are abnormal. I don't think we need any machine to tell us that this profile is completely different to this profile, although we are now able to quantify this abnormal activity with the softwares. But as you can see, it's almost pathognomonic, almost obvious when you see spontaneous activity in a nociceptor. When we have expanded this into animal models, these are rats on the left, rats with a focal nerve injury, crash, suture, or CCI, chronic constriction injury, all these animals with peripheral nerve trauma, they engage in spontaneous activity. You can induce polyneuropathy type of models in rats with STC to produce a kind of diabetes or DDC. And then you also see that either in focal or on polyneuropathy models, you have this spontaneous activity, which is almost indistinguishable of what you see in patients with small fiber neuropathy, that they have also these interruptions of the baselines of the nociceptors. So what happens on fibromyalgia? When we began recording on fibromyalgia, and the big surprise at that moment is that, we did small fiber neuropathy patients and fibromyalgia patients, and the big surprise is that a significant proportion of the patients with fibromyalgia also display spontaneous activity in the peripheral nociceptors. And that was a big surprise because at that moment, fibromyalgia, and still many people think fibromyalgia is basically, a pathology of the central nervous system, in which the central nervous system has been kind of, quotes unquote, high wire, and it's been sensitized, and then any stimulus from the periphery is kind of magnified or converted from the non-painful to the painful pathways, and then the patient experiences pain. But this is a thing that happens. Peripheral nociceptors in fibromyalgia patients are spontaneously active and very spontaneously active. So most probably they have something to do with the disease and the pain that these patients are suffering from. It's not only us. Since then, there's been a lot of evidence, and there are many more papers now of increasing recognition of peripheral neuropathy or peripheral abnormality, or at least peripheral dysfunction in patients with fibromyalgia. Another thing we can see is peripheral sensitization. So peripheral sensitizations, for instance, this is a patient that had extreme cold hyperalgesia. Normally, mechanoinsensitive nociceptors, the peptidergic ones, do not respond to heat. They don't respond to mechanical, and then, of course, don't respond to cold. But in this particular patient, they were responding to mechanical, heat, and also to cold with long-lasting discharges. So this is a case of peripheral sensitization of a unit that should not be responding to a natural stimulation from the outside, and it begins responding. This is the same subject. After a drop of menthol, after some minutes, you have an ongoing discharge in this fiber. So there are patients in which you have this phenomenon of peripheral sensitization. That's a normal fiber, okay? If I stimulate this fiber with a bone fry, there is a response. If I apply the bone fry again and again, and finally a hot rod or a heat stimulus, there are these responses. This is what we call marking. And this is a normal. This is a mechanosensitive and mechanoheat sensitive nociceptor. This is normal. That's what you should be expecting. And you have this other nociceptor of that patient with the heat, cold hyperalgesia. You apply a hot rod, and then you apply a air puff, cold air, and then a stronger cold air. And after this stronger cold air, you have this long-lasting discharge, which for us really explains the extreme cold hypersensitivity that this patient was suffering. She was telling us that every time that she was touching something cold, there was a long-lasting, actually burning pain triggered by the cold stimulus. What happens with fibromyalgia? Well, it's very similar. So you have patients with small fiber neuropathy in which you apply bone fries and they get sensitized, okay? And many patients with small fiber neuropathy, the sensitization is not only to mechanical, but also to heat. That's 50 degrees here. In patients with fibromyalgia, we see what we call an extreme mechanical sensitization. So you apply a bone fry here, and then you have this long-lasting discharge. So the same here, a very long-lasting, look at the minutes here. So this is 10 minutes every division. So for over 20 minutes after a single mechanical stimulation, this patient has a kind of ongoing, long-lasting discharge. The interesting thing of fibromyalgia is that most of the patients, the sensitization is to mechanical, it's not to heat. And this, in a way, would explain why these patients, particularly fibromyalgia patients, have mechanical hyperalgesia rather than heat or thermal hyperalgesia. If you compare what happens in terms of spontaneous activity and mechanically sensitized nociceptors, you will see that it's not so different between fibromyalgia and a small fiber neuropathy. So we didn't see any difference in the percentage of fibers that were spontaneously active. i.e. fibers that may be the electrophysiological correlate of spontaneous activity, and fibers that were mechanically sensitized. Very different from normals, that's for sure, but not so different between small fiber neuropathy and fibromyalgia. Another thing that we can see once in a while is this thing called multiple spikes. That's very briefly. So the nociceptors, when they arrive into the skin, they arborize and they branch in multiple branches. And then when we electrically stimulate them, we give electric shock, and then we see a single action potential. But this electrical shock has been generating many action potentials. The fact that we generate many, but we only see one, is because all of them, they conduct antidromically and they collide with the other ones generated in the arborization. So in the end, there is only one, the one that's closest to the parent axon, that is transmitted, conducted upwards, and that we can record it. But when there is peripheral neuropathy, in the fact, and there is dying back neuropathy, with the degeneration and regeneration, what happens is that many of these branches become unstable, and then there are these unidirectional blocks in which, with single electrical shocks, you can have multiple action potentials going up. So this is another cause of hyperalgesia, and this is you have these multi-spikes in which, instead of having a single response, all of a sudden these fibers have 2, 3, and 4 responses to a single electrical shock, like here, here, and here. So this is a kind of amplification of the message from the periphery. So you have to see it as a shift to the left of the stimulus response curve that these patients have. And then another thing that we can see in patients is these changes in the axonal membrane properties. For instance, these are patients with fibromyalgia in which you have extremes of conduction slowing at very low frequencies of stimulation. That's the thing that looks like very particular to fibromyalgia. It's very different from a small fiber neuropathy and from normal controls. And when we did this paper, this is in 2014, we hypothesized that there could only be 2 explanations for these extreme slowing conduction velocities at low frequencies. One would be that these fibers have less sodium channels, which we thought it was probably not the case. And the other hypothesis was that these fibers were thinner than normal. And curiously enough, after publishing this paper 1 or 2 years later, this is in fibromyalgia, this group produced this paper, which I think is very important. They did electron microscopy in the skin of these fibromyalgia patients, and they clearly show that the fibromyalgia patients have the diameters of the terminals in the skin are smaller than in controls. That's, I think, is very interesting, because probably is this only a reflection of a kind of dying back or very distal dying back neuropathy with regrowth. So probably these thinner axons are probably sprouts going on there in this type of patients. So this is in terms of fibromyalgia, but I would like to shift gears a little bit and show you this. This is a case, okay? And I think this is very illustrative, and let me go through it. So this is a lady, 39-year-old lady, which basically has a clinical presentation of burning pain sensation affecting both feet for the last 5 years. These feet are hypersensitive to touch. She doesn't want them to be touched. She was initially diagnosed with plantar fasciitis. She's a type 2 diabetic mellitus person, is slightly overweight. She also complains of the bowel rhythm is chaotic, and she has pain in the belly and the abdomen, and she has bouts of constipation and diarrhea. She also complains that she needs to go to the toilet very frequently. She has this sensation that I empty my bladder and 10, 15 minutes again later, I have to go again and again and again. She also says that when she stands up, she feels dizzy, she feels palpitations, she doesn't feel okay. And she also complains of pain everywhere, pain in the joint and in the muscles, deep aching pains. The nerve conduction studies were all normal, and neurological examination was basically normal. If anything, there was a mild pinprick hypoalgesia, a mild diminution in the pinprick sense in the feet. But because this was not a quantitative sensory testing, we don't know for sure. So my reflection here is that if this patient, goes to a GP and the GP says this patient needs to be referred, and I am going to refer this patient because the GP puts to refer it to the neurologist will end entertaining a diagnosis of a small fiber neuropathy. Okay, and we will agree that this, as a neurologist myself, that this is probably what will come to our mind for the first, as the first impression. But if we put a lot of emphasis in the bowel rhythm, maybe this patient goes to the gastroenterologist. And the gastroenterologist says in the end that this patient has an irritable bowel disease. But the same patient may go, to the cardiologist because the GP thinks that the disease spells are very important and these palpitations are serious. And then she goes to the cardiologist and the cardiologist says, well, this patient has a POTS. And finally, this patient, the GP, they like rheumatology and is sent to the rheumatologist because of the widespread joint and muscle pain. And the rheumatologist says fibromyalgia. So my reflection here is that you have the same patient with the same symptoms, and depending of what part of the elephant we are looking at, we arrive at a diagnosis or the other. So I would say this is 4 specialties, 4 diseases. And then each of the specialties will say, well, the neurologist will say, yeah, she has a small fiber neuropathy, and the rest of things are comorbidities. Yeah, burning pain in the feet, this is the small fiber neuropathy. Yeah, she has the comorbidity of a irritable bowel disease or a comorbidity of interstitial cystitis, for instance, or hyperactive bladder. So you have here, and this thing of the comorbidity is a thing I don't understand yet. So you have fibromyalgia, and then we all know that fibromyalgia associates with many things, okay, including POTS, burning feet, restless leg. And you go to POTS, and POTS associates with fibromyalgia, with, restless legs, and irritable, the same, small fiber neuropathy, the same. So you can mix the whole different symptoms, and then you have 4 diseases, all with comorbidities. And depending on which specialty is dealing with them, we say, well, this is one thing or it's the other thing. I honestly think that this makes no sense. I think that most probably, most of these patients have a single underlying problem, and this single underlying problem is giving you different expression in different body parts. And there are many other conditions like dry eye syndrome. You talk to ophthalmologists, they say, well, this is my nightmare in the outpatient clinic, right? These patients with itchy eye sensation or dry eye sensation, and you do the Schirmer's test and it's completely normal. Or you go to dentist, or you go to, and they say, well, many of my patients have burning mouth, irritable bowel syndrome, interstitial, some asthma types. We are now recognizing that some asthma types in young adults and in young patients are probably due to an abnormality in the peripheral sensory nerves of the bronchi. But tinnitus, or I don't know if you know this thing called cardiac X syndrome, which is basically a neuropathic pain of the heart, or Derkun's disease. So this is what I wanted to transmit here and open for discussion, because I think it's very important. So what is a small fiber neuropathy, right? Because we see that many of these conditions that I was explaining, when you do microneurography, you clearly see an abnormality in the peripheral C fibers, in the peripheral nociceptors. This links to this concept of a non-length dependent small fiber neuropathy. Yes, the classical small fiber neuropathy that we neurologists were taught when we were in medical school is that it's a symmetrical distal burning pain affecting both feet initially, and then may spread proximally, and then finally in the hands, and then in the rest of the body. But this is what we call quotes unquote classical small fiber neuropathy. But our understanding nowadays is that probably small fiber neuropathy is a much wider concept. You have small fiber neuropathy that are like this, no doubt, but there are many other conditions that probably are small fiber neuropathies, or at least small fiber nerve dysfunctions that express with symptoms in other parts of the body. And 2 of these big ones, for instance, is fibromyalgia and POTS. So I always think when a patient comes with fibromyalgia diagnosis, I always have this impression, is this the end of the diagnostic process, or this is just the beginning? So because when we say fibromyalgia, the only thing we are saying is special pain condition with special certain characteristics, but we are not digging into which may be the cause of these abnormal sensations of these patients. And for POTS, exactly the same. And for many other of the diseases that I was explaining, like, hyperactive bladder, for instance, or IBD, all of these could be also related to small fiber dysfunctions. And I think that's all I wanted to say today.
Thank you so much for that really fascinating talk, Sarah. That was great. Lots to think about there. As I put a message in the, if you could, if you have any questions, either stick on your online, either stick your hand up or put a question in the chat, and I'll do my best to answer it. I just wanted to open the floor to the people in the room first. Possible, come here.
Yeah. Hi, Dr. Sarah. How are you doing?
Hi, thank you. Nice.
Fantastic. Good. I loved your slide, that you had, these four corners covered with, POTS, irritable bowel syndrome and all that. However, you missed the most important person in the room, psychiatrist, because essentially, all these four diagnoses are going to end up, with psychiatrists, and all different specialties. Essentially, they're going to be waiting from us to give the solution to, really complex and chronic conditions. I mean, the majority of people that we see, at least, in my clinic, they come from a cardiology background. So essentially, with POTS. And, we do know, and there are a few reviews out there about, anxiety, depression, and personality disorders being as comorbidities in people with small fiber neuropathy, and specifically, with POTS, if you like. So certainly, I'm not saying that this explains everything, right? Don't get me wrong. But my question is, are there any studies looking specifically about the impact of psychiatric comorbidities on small fiber neuropathy? So how it affects the excitability of small fibers?
Yeah, I mean, it's a kind of fascinating, right? That we doctors, when we don't understand something, we always think it's coming from the brain, right? It's like we are making it up in a way, right? Or we have some dysfunction in the brain that's. And you're right. I'm sorry for this, and I take the thing that I may have to put the psychiatry label here because you're completely right, right? I don't know. I mean, any chronic condition in humans has a toll, so to speak, in the psychological well-being of a person, right? So, and this is a thing that in the chronic pain field, this was the thing that it was a big debate like 20 years ago, right? All these patients, they have depression and they have anxiety. And then when we began looking into other type of chronic pain or chronic conditions in humans, cancer, even without pain, the levels of anxiety and depression were not so different from the levels of depression and anxiety in chronic pain. So it's probably that this depression and anxiety, it may be linked to the experience of pain, of course, because you modulate what you feel and the expression of what you feel. But it's I would say it's more.
That was the key.
Yeah, but of course, this is a complex arena, right? Because you may have chronic anxiety and chronic depression without pain, and then all of a sudden you become, you develop a small fiber neuropathy, so to speak, and then you have pain. And of course, your background, your quotes unquote psychological or psychoaffective background, so to speak, is going to modulate how you live this experience, how you express, how you relate to others, how you interact with your friend and family, right? We're all built in a different manner. So what I think is a mistake is that we don't understand what's the cause. This is coming from the brain. Stop. I think this is a mistake, and I always say this distinction between peripheral nervous system and central nervous system, a kind of artificial construct that we have, is the nervous system. And the nervous system at what end has receptors to cold and to heat in the skin, and at the other end in the brain, it has, circuits to interact with the environment, right? So it's all the whole thing that gets disrupted in this kind of patient, right?
Thank you.
It's very complex.
Thanks, Fospo. I think Tim, you had your hand up first. I'll go to you next. That's okay.
Thanks, Jordy. Great talk, and it's so great to see the sort of data that you've been working on. And I think it's really important, I guess, as you alluded to there, that it's not necessarily just one thing or another. Things aren't necessarily just peripheral or central. There's a complex interaction over time. Things can change from initially very peripheral or physical to sort of secondary cognitive mechanisms, and there's this dance and interaction between the two, which I think is so important. And I guess just picking up on the point about the POTS, but it might be too simplistic an explanation, but you have the fact that anxiety and hypermobility and the sort of collagen, the way that the autonomic nervous system responds, and the way that anxiety is a physiological state. We forget that all our psychiatry is organic and physical on some level as well. So these sort of old-fashioned approaches, I think, what you're doing can really help to unpick that. But I'll be fascinated to know if there's any data on following people over time with this, and at what time points during different disorders. So, if you can imagine following a group of people who've got early fibromyalgia and then late, and what happens with your findings there. I presume no one's got enough data to know that. But final point is whether, should there be a type 1 and type 2 fibromyalgia on the basis of this work, a bit like CRPS is currently. A couple of things in there for you. Thank you.
Yeah. I mean, I don't know. I honestly don't know. I don't think we have large enough studies and to have the whole spectrum of fibromyalgia patients. There is always a big danger here as well, which I am very well aware of, which is referral bias and sample bias. Right? So here at the hospital, for instance, Nick Gold sends to me lots of patients with POTS, and we see small fiber neuropathy or small fiber dysfunction in many of them. But when you talk to him, he said, well, I only refer to you the ones I have a suspicion they may have something else. You know what I mean? So I'm not seeing all the spectrum or universe of POTS patients. I'm seeing a sample of these patients, which is probably highly biased. So with the fibromyalgia, it's the same. I mean, in our cohort of patients, up to 70% have abnormalities. But we didn't go and have, a population of unbiased sequential fibromyalgia patients, and we're taking all of them on board. So one has to be extremely cautious about these things, right? But at the same time, we can say without any doubt that there is a significant proportion of patients that do have these abnormalities. It's a little, and because it's early stage with everything, we actually don't know where we are. It's like long COVID. I mean, we are beginning to record from long COVID patients, and some of them have abnormalities in the peripheral nervous system, and some of them complain of pains and deep achings and things like this. So it's possible that a proportion of these patients will have small fiber neuropathy. But is long COVID a small fiber neuropathy? Probably not. Yeah. Probably long COVID is many things, and one of them is probably small fiber neuropathy. So I would say be aware of sample bias and referral bias, right? Because it's pervading everything.
Just finally, just quick before you had, sorry, just very quickly to space that I think obviously the one thing with FND, and we know, is that it often grows from an organic condition. So it's just having a physical condition of some sort predisposes you to get a functional disorder. So it's, and again, not surprising things to most people, but it's just a simple thing that's easy to forget, that just the loss of what might be driving something that could also have a functional component is having an underlying physical disease, like we know with epilepsy or other neurological conditions. So just it's easy to forget that. But sorry, thanks.
Thanks. I might just do one question from the chat, and then I'll come to you, Nick, if that's okay. So we have a question from Georgia Eleni Theodoraki, which was, I was wondering how we can explain the efficacy of SNRIs like duloxetine in fibro if the pathophysiology is more in the peripheral rather than the central nervous system.
Oh, well, because, I mean, if you interrupt the message from the periphery into the brain, or you modulate how the message is interpreted and processed in the brain, you can affect the pain. There's no doubt about that. I mean, but this is a thing that can even be done at a psychological level, and it's a common experience in chronic pain doctors, so to speak, and we know that patients that they have chronic pain in the feet because of small fiber neuropathy, when they are watching a very interesting film or very exciting film, they kind of quotes unquote forget about the pain. It's not that they forget, it's that the brain attention gets shifted to another place. So there are neurotransmitters here and there, and the message, it's interpreted and modulated in a different way. So the fact that peripheral neuropathy responds to centrally acting agents does not rule out that this is coming from the periphery at all. It's that you are modulating the message higher up.
Fantastic. Thank you. Thank you. Nick, should we go to you next?
Yeah, thanks for a very interesting talk. I mean, just one very brief point and then a question. So a brief point, I suppose, just picking up on Tim's point about not falling into the the trap of mind-body dualism. I mean, irritable bowel syndrome is a really good example of that, where, of course, you can measure abnormalities of bowel peristalsis, you can measure, physiological anomalies, but I think pretty much everyone would, it's kind of non-controversial, really, that irritable bowel syndrome, the symptoms have some kind of relationship to emotional arousal and stress levels and so on. So it's neither, purely psychological or physiological, it's psychophysiological in the true sense, and I think we're probably dealing with something similar here. And so on that note, you sort of touched on this actually with your answer to the previous question. I mean, I remember decades ago as a student learning about Melzack and Wall's gating theory of pain. I don't know whether that's still current. I'm sure it's been very much modified over the years since then. But I'm wondering about the top-down influences on the kinds of physiological activity that you're recording with your microneurography. Is it possible for those to be modulated by things like mood, anxiety levels, mental state in the broader sense?
My direct answer is yes. I am convinced it can be modulated. And even if it looks counterintuitive, I think the excitability of the axonal membrane, the periphery, can be modulated by centrally acting processes, so to speak. Has this been demonstrated? No. But curiously enough, we are beginning now a nice study on placebo, and we are going to be looking into changing the peripheral excitability through placebo effect, which could be a very massive thing, right? Because placebo has always been classically thought this is a central effect, a central phenomenon. But as I was saying before, the distinction between PNS and CNS is artificial. It's completely artificial. It's the NS, it's the nervous system, right? So one example, for instance, is sleep deprivation. Okay, we know that if you don't sleep for 24 hours, you will begin aching. You will have aches. Your body will ache, and if you don't sleep in 48 hours, you will not only be aching, you will have spontaneous pain everywhere. So one would be thinking, well, this spontaneous pain is a central phenomenon. It's the brain that all of a sudden gets sensitized. But we know very clearly from animal experiments is that most probably what happens is that there are circulating cytokines, and you name it, that sensitize these peripheral fibers. So yes, sleep is a central property, or is a property of the brain, so to speak. But the effects of not sleeping will produce symptoms that may be centrally originated but peripherally mediated. You know what I mean? So, and this applies for anything. If you have anxiety, so if you have a peripheral neuropathy and your fibers are unstable because you have hyperexcitable axonal membranes, most patients tell us, when I am relaxed, I have less pain. When I am anxious, I have more pain. That's a common finding. And we all agree that this happens with patients. Is this a centrally mediated thing, or it happens that whenever the patient is more relaxed, they breathe differently, so the CO2 is different in the periphery, the free calcium is different, the levels of adrenergic hormones are different, and then there's a little change in the excitability, enough for these fibers to stop discharging for a while. So it's a very complex thing. It's not central or peripheral. It could be that the whole thing is influencing each other, right? So yeah, I would say that in many instances the peripheral nervous system is a bystander of what's going on, right?
Yeah. Okay. Thanks. That's very interesting. Thank you.
Well, one of the next questions we have in the chat is from Earl, who is in the room with us. Earl, did you want to come and ask the question? Earl, did you want to come and ask the question you had?
Hi. Yeah, good. Can I speak now?
Yeah.
I just wondering about the false positive or false negative of the result. What should we be careful when interpret the result of microneurography for the patient? Yeah, thank you.
So I don't know if I understood well the question. If one should be...
It's about false negatives and false positives.
Yeah, false negatives.
Yeah, absolutely. Yeah. So here is, but this is like any electrophysiological technique, right? So if you put a needle in the muscle and you see polyphasic potentials and you see spontaneous activity, there is going to be, that does not mean by necessity a radiculopathy. So we all know that there's going to be false positives and false negatives. That's for sure. So what we can say about microneurography is that the vast majority of healthy volunteers do not have spontaneous activity in the peripheral nociceptors. Okay, and this is kind of logical because otherwise we would be experiencing pain. So we have a peripheral nociceptor system that's waiting to be activated to signal pain to the brain and then to elicit all these, defensive maneuvers. So spontaneous activity is an abnormal phenomenon. And I would say it's the necessary condition for the experience of spontaneous pain. Necessary, but not sufficient. And that's the crucial point here. And here is where the false positives can come in. So you can have spontaneous activity in the peripheral nervous system that does not cross, quotes unquote, into consciousness. Because to cross into consciousness, you need some special and temporal requirements that need to be fulfilled. So you need a certain frequency and a certain number of fibers to be discharging simultaneously for this afferent barrage to go into consciousness. They will reach the thalamus, but sometimes it doesn't go into consciousness. So one has to be careful. Yes, false positives and false negatives. I would say that the false negatives in microneurography are very low, very low.
Thanks. Next question in the chat is sort of tying together some of the things I think we've kind of already been discussing, but I think it's an interesting question. Is there any evidence that small fibers can be damaged or become dysfunctional from, for example, emotional trauma, perhaps in relation to information?
Well, that's a very interesting question, right? Because, I mean, I have a very eclectic approach to things, right? But I would say that probably yes. For the same kind of explanation I was giving before. Things. So when we have intense emotions or intense, anxiety, and the body is reacting. There are hormonal and biochemical and inflammatory changes in the body. And these changes in the body may be affecting the peripheral nervous system, right? So this is like myochemia. I don't know if you know this thing, myochemia, right? You may have antibodies against potassium channels, and then all of a sudden your axons in the periphery will become unstable and they will produce myochemia, right? Is there a neuropathy there? No. The nervous system is a kind of bystander, right? If you stretch the thing, myasthenia gravis is exactly the same. Is myasthenia gravis a neurological disease? I would say no. It's an immunological disease in which the neuromuscular junction happens to be the bystander. You know what I mean? So can intense emotion, intense anxiety in the long term, or not even so long term, have hypothetically an effect on the peripheral nervous system? I would say yes. And this is a fascinating field for study.
Fantastic, thank you. So we've probably got 5 more minutes or so if anyone wants to put in any last minute questions. And we have a question from Imogen, who says, consultant psychiatrist here, ADHD patients often present with this quite often. I'm guessing she means small fiber neuropathy, but please correct me if I'm wrong. And are there any studies linking the 3? So ADHD, neuropathy, and long COVID?
Not that I'm aware. Not that I'm aware, no.
Great. So we also have a question from Caroline Jolly. Well, more of a comment, I suppose. Jordan and I have been discussions about, so Tim posed the question about the link between respiratory disorders and small fiber nerve dysfunction. And is it possible to perform from other sites? So I guess the microneurography, is it possible to perform from other sites?
You mean from other nerves, you mean?
I'm guessing that's the
yeah. Hi Jordi. Yeah, I was thinking about cough, and I was thinking about muscle function and breathlessness. So obviously the measures that you use are from the common perineal nerve, but I was wondering if it was possible to record from any other sites at all, like muscle or maybe the respiratory tract.
I mean, during the 30 or 40 years of the life of microneurography in the world, people have been recording from many nerves. The latest or the more relevant to you maybe Is there is a guy in Australia that recorded from the vagus nerve. So apparently it's very easy to record from the vagus nerve because and it's very safe to access it here because the microneurography needles he accessed it with ultrasounds, but the microneurography needles are so thin that it's almost impossible to penetrate the carotid because of the muscular layer. So there's no risk of injury there. Okay, so yes, it's possible to do microneurography from other nerves.
Okay, perfect. Yeah. Thank you.
There's a question from Ross Mandeville about advice for setting up a new lab doing microneurography. I wonder if that's perhaps best answered over email, if that's okay. Just sticking to sort of more clinical focus question from Sonali. Are there studies on effective medication for treatment of fibromyalgia? For example, do they reduce spontaneous activity, hyperexcitability, or multiple spikes?
Yeah, there is a scarcity of I have been involved in 2 clinical trials using microneurography as the primary outcome. What we have to say is that spontaneous activity in C fibers, in nociceptors, is highly resistant to the known things. So even IV lidocaine is very poor at stopping this spontaneous activity. So, and that's probably the cause of why neuropathic pain is still in need of new treatments, right? There is a big effort now with subtype, sodium channel, subtype specific sodium channel to try to tackle this problem. But we'll see what happens. And this relates to the actual cause of the spontaneous activity in acquired neuropathies, not in genetic neuropathies, in acquired neuropathies, which has to be, it has many anatomical reasons of why these fibers are spontaneously active.
Wonderful, thank you so much. So thank you for fielding all those questions, Dr. Serra. I don't want to speak on your behalf, but I'd hope that if there are further questions that you might be able to respond to them over email, if that's okay.
Sure.
Thanks again for a really, really fascinating talk. It's 2 minutes to 2, so probably draw it to a close now. Just before we finish, to say that the next meeting is in a fortnight's time at the same time, and the topic title is Distinguishing Psychiatric and Neurological Disorders, the Role of Neurofilament Light, and that's Professor Dennis Velakoulis from Royal Melbourne Hospital who will be delivering that talk. So hopefully see many of you there in a fortnight's time. And thank you so much for everyone who's